Welcome everybody. Today we're going to be discussing the second chapter in my dissertation, which is on medical care prices. Okay. So let's begin by looking at this graph of headline inflation versus medical care component of inflation. Right? And so if you look in this graph, you'll see that in the dark line is the headline rate of inflation given by the CPI, and the dashed line is the medical care component of the CPI, which is roughly about 7.5% of the normal CPI. Now you can see it every single year, just about, the medical care CPI is actually higher, right? So even in this period after 2000, where it looks like they're pretty close, during that period of time, the CPI averaged about 2.5%. Whereas the medical care component still averaged about 3.8%, or about 1.5 times as high. Now, the question that a lot of healthcare economists have had is, does the CPI, or the medical care component of the CPI, accurately reflect the inflation rate of medical care in the economy? Right? And so the emphasis of this paper, what I'm trying to do in this paper, is trying to determine, first, is the medical care component of the CPI actually biased? Right? Does this component accurately reflect the inflation rate for medical care in the United States economy? Now, a lot of papers out there that say that there is a bias, roughly about 1%. And once you take account of that bias, then the CPI, the medical care component of the CPI, isn't actually that much higher than the normal inflation rate in the economy, right? And so what a lot of researchers have done in the recent years is they've constructed alternative price indices that better account for problems that are in the CPI, right? And so one of the things that I'm also doing in this paper is I'm addressing those alternative price indices. And I identify two effects, right? One is on medical outliers, and the second is on aging. And I show that both of these can actually cause the alternative price indices to underestimate medical care inflation. And once you take into account both of these effects, then the medical care component of the CPI might actually be understating medical care inflation as well. Okay? So, the motivation behind this paper comes from these earlier studies. So, they first began with Ann Skatowski in 1967, in which she looked at the treatment for 5 different diseases in a Palo Alto clinic in California. And she found that the treatment of these 5 diseases was actually higher, right? The cost of treating these 5 diseases was actually higher than what the CPI was indicating it would be, right? Now, she came up with a couple of ideas of why she thought this was. For instance, during the period of her study, Palo Alto was a very rural area that had turned into an urban area, and so she thought that that was one possible explanation. But she didn't fully believe that that was the only thing driving her results, right? Now, most healthcare economists, while they recognized this study and knew about it, they kind of, put it aside until Shapiro and Wilcox came around, and they decided to estimate the inflation rate for cataract treatments. And what they found was that the treatment for cataract, the inflation rate for cataract treatment, was actually much, much lower than the inflation rate for medical care in the CPI. And so they investigated this further and found that The reason why was because for cataract treatments, at the beginning of their study, most cataract treatments were involved an inpatient procedure at the hospital. However, through the course of their study, they found that a lot of the treatment had been substituted into an outpatient procedure, right, which was relatively less expensive. And the CPI for medical care didn't actually fully capture that substitution effect. Now, it's true that all consumer price indices, all components of the CPI, also suffer from the substitution bias. And that's the reason why a lot of people argue that we should use the chain CPI instead. However, what Shapiro and Wilcox indicated was that the substitution bias may actually be greater in the healthcare sector than in other sectors of the economy. And this was also, the same conclusion was reached by Byrne in a series of papers as well. Now, another very important study in healthcare economics was by Cutler, McClellan, Newhouse, and Rimler in 1998, in which they looked at the cost of treating heart attacks. Now, what they found was that while the cost of treating a heart attack over their time period in the study may not have increased by a lot, right? What they found, though, was that the outcomes of the treatment were much better, right? That people, as time was going on, people were living longer from the treatments, and their quality of life was much higher following the treatments as well, right? And that type of quality of treatment was not actually captured by the CPI for medical care either, right? And so they proposed a quality of life adjusted price index for measuring inflation for heart attack treatments. And their conclusion was that once you take into consideration this quality adjustment, then healthcare costs may not actually have risen faster than other costs in the economy. Now, one thing that I should say is that for my work, I've seen that productivity for heart attack treatments or treatments for circulatory diseases is probably the fastest growing sector as far as productivity goes in healthcare, right? So that may not be the best study to accurately represent how everything's going on in the healthcare sector, right? But furthermore, this quality of life adjustment is pretty controversial in actually applying to the healthcare sector as a whole for calculating medical care inflation. All right. Now, the one thing that all six of these papers highlight is the fact that the CPI for medical care is not accurately reflecting cost for some people in the economy, right? And the reason why is A, because it does not allow for the substitution across different types of services, like inpatient procedures to outpatient procedures or towards medicine, right? So, for instance, if you look at heart attack treatments, 50 years ago, a heart attack was treated by cutting open the patient, maybe stopping their heart, and then performing surgery. Whereas now, a lot of heart attacks can be treated with just some medicine, right? Which is much more cost effective, right? Now, the way the CPI works is that the CPI actually holds the quantities of each one of these services fixed and just tries to examine the change in prices. So in other words, the CPI for medical care might look and say, okay, well, let's keep the number of hospital stays in that the average person has constant, right? And then let's just see how much it costs to stay a night at the hospital. Now, the problem with that, though, is that as healthcare becomes more productive, right, as these treatments become better, then a lot of these inputs are going to be reduced. And so the outcome then is that the medical care component, the CPI, is not allowing for productivity growth. Okay? And so the Committee for National Statistics saw this, and they recommended that the Bureau of Labor Statistics actually create a completely alternative price index for medical care. To start off as experimental, but see if they could begin incorporating that into the official consumer price index. And their recommendation involved, randomly picking 15 to 40 diseases and tracking how much it actually costs to treat these diseases over time using insurance claims data. Right? And the initial paper by Sung and others that investigated this in 2009 found that the CNStat recommendation was probably not very good. One thing was that insurance claims data tends not to be nationally representative, and plus, only tracking 15 to 40 different diseases didn't really give you a picture of how medical care inflation throughout the entire economy was actually behaving, right? And so other researchers at the BLS and BEA decided to take this study and improve upon it, right? To actually, instead of picking 15 to 40 specific diseases, let's actually aggregate, all these diseases into categories and look and see, what happens when the treatment of, say, respiratory diseases, or what happens to the inflation rate for the treatment of respiratory diseases, or maybe even more specific, what about the cost of treating the flu over time, right? And so all of these papers that did that, starting from Bradley et al. In 2010 all the way down to Bradley in 2013, or a recent working paper by Dunn in 2014, they found that that the CPI was biased by about 1%, right? So if the CPI for medical care was estimating the average rate of inflation being about 3.8% in the 2000s, then in reality, the medical care inflation rate was only about 2.8, which is only a little bit above the CPI, right, or the headline rate. So let's investigate this a little bit further. Okay. So what I've shown here is the service price index on the left, which is essentially how the CPI is calculated, CPI for medical care. And on the right, we have the medical care expenditures index, which is what these other studies in this table are actually using to calculate inflation. Right? So in the SPI, what you can see is that P is equal to price, Q is the quantity of the service, which S is the service, T is the time period, and 0 is the base year. And so in this particular formula for the SPI, you can see that the CPI is calculated by holding the quantity of each type of service fixed, right? And then just estimating how prices are changing over time, right? So if in, say, 2000, the average medical consumer spent 3 nights at the hospital, then Q would be fixed at 3 for the entire period, and they would just see, well, what's the cost of staying a night at the hospital, right? Now, the MCE on the right, though, is a disease-based index. So the idea behind this is that, now typically, when this BLS tries to calculate the CPI, what do? They try and determine how the price of a particular final good is changing in the economy. Now, the problem with healthcare, though, is that things like a stay at the hospital or a visit to the doctor's office, those aren't final goods. Those are intermediate goods in the production of a final good, and that final good is healthcare, right? Is health. And so the way the MCE works is instead they look at the cost of treating a disease. So instead, they keep the quantity of diseases from period to period fixed, right? And instead look and see, okay, well, what is the average cost of treating, say, a heart attack in 2005 versus the average cost of treating a heart attack in, say, 2004. So in this case, both price and quantity are allowed to change. Right? So this way you're looking at expenditures. And so this allows for productivity or substitution effects to be calculated in the price inflation for medical care. So that if the treatment for heart attacks is becoming more productive, so that you need fewer stays at the hospital, maybe fewer visits to the doctor, maybe more medicine instead, then what's going to happen is that now, maybe the price will rise for a stay at the hospital, right? So PS will go up, but since the treatment of the heart attack is becoming more productive, what's going to happen is that Q is going to fall, right? And so this provides a measure that's more similar to how the CPI calculates prices for other types of goods in the economy, right? And so this is the preferred method by a lot of health economists who are doing work in this area. Now, the problem, though, is that the MCE doesn't really reflect the price inflation for the typical consumer. And that's what we're going to see. So if you look a little bit more closely at this formula for the MCE, then one thing that we should realize is that there are a lot of outliers in healthcare spending. For instance, in the data set that I'm using here, that the average expenditure on a treatment is actually 4 times greater than the median treatment or expenditures on the treatment. So, for instance, even if you look at like a very specific treatment, like a heart attack, right? Now, some people might have a very minor heart attack, and they can just take some thrombolytic drugs, and that's all they really need, right? Whereas other people, they do have to go into a major surgery because maybe their heart attack's a little bit more severe. And instead of just taking a handful of pills, they might have to stay in the hospital for a month or two. In my data set, I have people of all different types and severities, right? And so you have these huge outliers in health spending. And so when you calculate the MCE, these outliers would only be a problem if the inflation rate for high expenditure treatments is different from the inflation rate for low expenditure treatments. And the reality is that that is going to be the case, right? So the cost for just taking a few medication, for taking just a few pills, is going to be growing at a different rate than the inflation rate for, say, a stay at the hospital or surgery, right? And so what's going to happen is this means that the mean is not going to estimate the inflation rate experienced by the typical consumer, right? And so what we're going to do in this paper, in addition to estimating the MCE like other people have done, we're also going to use some other methods that are more robust than the mean, right? So we're going to use the median, but we're also going to use some other methods such as the Hoover-Tukey M estimator and also the modified M estimator or MM estimator. Now the benefits of the MM estimator is that it's similar to the median in that it has a very high breakdown point. So for the median, roughly 50% of your data has to be bad, right? More than 50% of your data has to be bad or corrupt before the median gives you a biased answer, right? And the same thing with the MM estimator, right? But the MM estimator is also very efficient, which the median is not. And so the result is that the MM estimator actually gives you something that's sort of in between a mean and a median, okay? And so we'll be looking at that in addition to the median and the traditional MCE index in this paper. Now, in addition to that, what I'm going to do in this paper is I'm going to address something, another form of bias, and that is the aging bias. Right? And this is something that I haven't really seen other papers do. Now, other papers do look at what is the effect of a change in demographics or the effect of an aging of the population on the inflation rate. But that's not what I'm talking about. Right? When I'm talking about aging, I'm talking about it from the perspective of the health consumer themselves. So someone who is 30 years old one year is going to be 31 in the next year. So not only are the medical expenditures that he's currently consuming, right? Not only are they going to be rising due to the inflation rate of medical care, but there's also this effect that as he's becoming older, right, he's going to be using a different, or he's going to be receiving a different set or mix of treatments than he was the year before, right? So if you compare, say, a 10-year-old kid who most likely, if he's going to go to the doctor, it's going to be maybe for the cold or maybe a sprained ankle. Whereas fast forward to, the average 60-year-old or 65-year-old who's probably going to go to the doctor for, high cholesterol or diabetes, right? Or, God forbid, cancer, right? And the treatment, the average cost for treatment for an older individual is going to be much, 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 much higher than the average treatment cost for a young individual, right? Or a young kid. And while it might not seem like that much, because you're thinking about, say, a 50-year time period, how much is the average inflation rate, or that aging bias, going from 30 to 31? What I'm going to show is that that's much larger than has previously been accounted for in the literature. Okay? So let's start by looking at our data. So this paper, we use the MEPS data, or the Medical Expenditures per Panel Survey data. And we're using years from 2003 to 2011. Now, many of the other studies that have tried to estimate or calculate the medical care expenditure index have used the MEPS. And the reason why is because it is a nationally representative sample, which you typically don't get with insurance claims data, right? But also, the MEPS is the only publicly available data set that includes data on uninsured patients, right? Now, the problem with the MEPS, though, is that there are really only about 35,000 individuals each year. And so that means that high expenditure treatments do tend to be underrepresented. So that's just something to be aware of when I'm talking about outliers, that the MEPS may not be the best data set to use for that. However, in order to better compare my results to previous studies, I believe that the MEPS is the optimal data set to use. Okay? So the MEPS is broken up into a series of different event files, right? So whenever someone's surveyed in the MEPS, right, and they list, how many times they went to the doctor, what the cost of each visit was, what kinds of services were included during that visit, right? So each one of those office visits or prescription drugs or hospital admissions, all of those things have a separate event file associated with them. Right? And so what we're going to do is we're going to focus on 5 of those different types of events. Office-based visits, prescription drugs, inpatient procedures, outpatient procedures, and emergency room visits. Okay? Now, the big question is, how are we going to treat output? Right? Because you can't talk about, how is the price per unit of output rising or changing over time if we don't have a clear definition of output. And so just like for the MCE, what we're going to do is we're going to consider a unit of output to be the treatment of a medical episode over a 1-year period. Right? Now, obviously it would be more ideal if we had a longer, say, time series of each treatment, but given the data, we have to limit the treatment of the medical episode to only be over 1 year. Now, luckily there are a lot of observations for many of the diseases, so this shouldn't be a problem. And for most diseases, it's not a problem. The big ones that kind of stand out are things such as treatment for hypertension or diabetes, which are ongoing and chronic, right? And so it's very difficult to actually say, well, what is a complete treatment of the medical episode, right? And so we're going to stick with the treatment of the medical episode over a 1-year period, right? And so and of course, this has been discussed by a lot of different papers. And so the benefit of doing that is that the MEPS database actually links all of the events to a single medical episode. For instance, say someone has or becomes pregnant, right? And it's a normal pregnancy. Then that person's probably going to make, a handful of trips to the doctor, maybe, take some nutritional supplements that are prescribed, and then maybe end with an inpatient procedure, right, or delivery, right? And so with the MEPS, I can actually link all of those individual office visits and the delivery and the prescribed medication all to a single episode. Okay? And so that makes it very convenient. And so from 2003 to 2011, I've identified 480,000 plus episodes in the data. Okay? Now the big one is, how do we define a disease? Right? Because if you go back to when I discussed the medical care expenditure index, which is the commonly used alternative price index that's being investigated by the BLS and the BEA, then that is aggregating the different diseases together to create disease-based smaller indexes that they then aggregate to one bigger index. Now, the problem is that there are a lot of different diseases. So are we just going to, pick a handful of diseases? If we just pick a few, then we might not be fully representing how medical inflation throughout the economy is actually behaving. But at the same time, we can't treat each disease individually. For instance, if you look at diseases coded by their ICD-9 code, there are over 14,000 different disease codes there, right? And so that just would not be feasible to create 14,000 different disease index. So some level of aggregation, right, is important. Now, a lot of studies will use commercial software, like the medical episode grouper, right? But these are expensive, and since I'm a graduate student, I don't really have access to that yet. Plus, there have been studies, specifically a recent one a working paper done in 2014, in which they show that, which commercial software you use impacts the results significantly. And we're even going to see a little bit of that in my study here. Okay? So alternative ways that we can define diseases is we could use this ICD-9 code. Now, though I said that there are 14,000 codes, that, within the data, there are 669 that are populated at just the 3-digit level, right? Which is a slight aggregation from the individual 14,000 code level, right? But in addition to that, we could use the different broader categories, which is used by Bradley in 2010. And so, in this case, there are 19 broader categories in the MEPS data. Or we could go a little bit lower level than that and use the about 200 different subcategories. Now, an alternative method used by a lot of researchers is to use the clinical classification code. Okay? And this clinical classification code is put out by AHRQ, and what they do is they group some of the ICD-9 codes that are similar from an expenditure standpoint. They group them together. And so a lot of researchers believe that this is probably a better way to aggregate diseases than just using the ICD-9 codes. And so I found roughly 256 different codes at the 3-digit CCC level. Okay. And so here are the summary statistics. And like you can see, the mean expenditure over the sample period is about $1,900. Right? And the median expenditure is close to about $500. And you can see how they're split up between the different categories. So office-based expenditures are about $486. Of course, that represents an average of 3 office-based visits, right, for the average treatment. And you had the average outpatient procedure cost per treatment is $178. But of course, you have to recognize that only a quarter of people in the sample even have an outpatient procedure, right? And you can go through and you can easily see that the results are highly skewed. Like when you come over to, say, inpatient procedures, you'll see that, at least one person had expenditures of almost $1 million, and that's just for the inpatient. That's just for the inpatient procedure. So that includes stays at the hospital and everything. Okay. So let's calculate average inflation. So on this table, I've shown the core CPI from 2000, the average annual inflation rate given by the core CPI from 2003 to 2011. That's about 1.92%, whereas the headline rate's a little higher, 2.5%. But the medical care component of the CPI is about 1.5 times the headline rate at 2.5%. Right? And then, so first, I calculated my service price index, which is my version of the CPI using the data that I have and the available services that I have from the data. And as you can see, I get pretty close, 3.72%, right? Very, very close to the medical care component. Obviously, it's not going to be the same because the medical care component of the CPI does include dental visits, does include home health care, and a number of other things that I'm trying to stay away from a little bit more in this paper to make it more similar to other studies. Okay? Now, then let's look at these other estimates of the MCE. Now, what I've done here first is instead of fixing a disease weight like the other studies have done, first what I'm doing is I just let the disease weights fluctuate from period to period. And that way we can compare that to results from other studies. And so when we do that, I see that the MCE is actually about 3.62%, which is actually very, very, very close to my calculation for the SPI, right? And in fact, what this would say is that the CPI for medical care is really only biased by about 0.1%. Yeah? Now, again, this is allowing the disease weights to fluctuate, which might not be optimal, right? In a moment, in the next slide, I'll show you what happens when we actually keep the disease weights fixed. Right? Now, when we estimate the median, we actually see that the median is much higher than the SPI, right? So that would actually say that the CPI for medical care is underestimated by 0.2%. That might not actually be correct, right? And then you can see that we also have the alternative methods shown here. Now, when I actually allow the disease weights to be fixed, right, then we see our estimates change considerably. So here I've used two different methods. One, I've based it off of the clinical classification codes, which is very similar to many of the recent papers. But I've also aggregated it by ICD-9 category. And so in this, I'm looking at those 19 categories, which is probably a little too disaggregated, right? But this is more similar to the original Bradley study in 2010. Okay, so in this case, with the CCC, clinical classification codes, what you can see is that the MCE is calculated to be about 2.77%, right? Average annual inflation. And that's about 1% lower than by estimate for the SPI, right? That falls in line perfectly with all the other studies that have recently looked at this. With the CCC, the median's actually a little bit lower, right? And then the MM estimator's a little bit higher. Now, at the ICD-9 level, the MCE isn't quite as low, right? So in this case, average annual inflation would only be estimated at roughly 3%. So that's about 0.25% difference between the exact same data, right? But using a slightly different disease aggregate. So we can see how important actually picking the aggregation level of the diseases actually is. It can make a huge difference, right? And we can see that in this case, the median's actually much higher. It's about 0.35% higher than the mean-based method of the MCE. And the MM estimator's a little bit in between. So what these show is that the median which I would say represents more of the typical health consumer than the mean method, reports that inflation is up to 0.3% higher than that given by the MCE, right? Now, of course, what's going to need to be happening is we need some better data, probably more comprehensive data, to actually investigate this a little bit further. Okay? And if we can see at the bias that when we just let the MCE fluctuate, or the disease weights fluctuate for the MCE, then the bias really isn't very high, right? So here we're allowing substitution across disease treatments. But once we actually fix the disease weights, then the MCE is still reporting that the CPI, the medical care component of the CPI, is biased by perhaps up to 1% or so. And like I said, that falls in line with other studies. Okay. Now, if we look at the inflation rate by ICD-9 categories, and these are a few listed here by the different ways, we can see is that from this first column over here, that the inflation rate fluctuates significantly across different diseases. So if you look at neoplasms, which would include things such as cancer or benign tumors or those things, then the cost of treating those diseases is going up by over 5% per year. Right? Whereas if you go down to circulatory diseases, it's actually falling from year to year. Right? So it's actually experiencing some sort of deflation. Now, I haven't listed utilization growth here, but it's pretty easy to see that that these inflation rates are related to the change in utilization of resources used in treating these diseases. And I'll talk about that a little bit later, but the correlation between those two is about 0.92. Right? Okay. Now, one of the things about this is that since most of the results in the earlier table showed that the median may be up to 0.3% experiencing 0.3% higher inflation than the average, then that indicates that the cost of treatment is different across different expense quantiles, right? And we can actually see that in this graph. So on the left side of the axis, we have the average annual inflation rate, and on the bottom we have the different expenditure quantiles, right? So for very low, for treatments that aren't very expensive, right, which is, 60-70% of the treatments out there, then the inflation rate's pretty high, almost 4%. It's only when you get to the expensive treatments, the top 20-25% in terms of expense treatments, the ones involving hospital expenditures and outpatient procedures, stays at the hospital, all of those things, only for those procedures are you really seeing the inflation rate be pretty low, right? And so the cost of expensive treatments is growing relatively slower than those of inexpensive treatments. And so it was looking at this that I became interested in what is the effect of, or how is this related to aging, right? Because older individuals tend to have more expensive treatments, right? And younger individuals tend to have less expensive treatments. So, again, the story I had earlier, most young children just go to the doctor to see about a cold or a sprained ankle or something like that. Whereas older individuals are more likely to actually be treated for things like heart attacks or diabetes, which are much more expensive to treat, right? And so that falls in line with this previous result, where if you look at the circulatory system diseases, they're experiencing very low rates of inflation, right? And same with these endocrine-related diseases, which would include diabetes. Whereas when we look at respiratory diseases, they're growing at 4.19% per year. The cost is growing by 4.19%. Okay. So, what does that mean? Well, first of all, when people age, their treatment costs are more likely to rise, like I just said. And so that would mean that the inflation rate for that particular age group is going to be lower than others, right? So if you look at the inflation rate for elderly individuals, it should be lower than the inflation rate for, say, 10-year-old kids. But at the same time, the inflation rate for that 10-year-old kid is going to have another compounding effect. And that's going to be because that 10-year-old kid is getting older. So next year, he'll be 11, right? The year after that, he'll be 12. And what that means is that the types of things that he's going to be going to the doctor for is going to be different. Now, for a 10-year-old, that might not be too different, right? But when you're talking about someone that's 40 going to 41, or someone's 50 going to 51, or even 30 going to 31, then that can make a pretty significant impact on the inflation rate from that individual's perspective, right? So let's look at an example down here. So if you think about respiratory diseases, which were the most common types of diseases there that children are treated for, 26.24% of all treatments for children 18 and younger are respiratory diseases. However, only 6.73% of all treatments for adults 65 and older are respiratory diseases. And what's the average expense for these? Well, the average expense is about $1,029.85, and the average inflation rate is about almost 5%. Right? Now, one thing to understand is that this average inflation or this average expense is going to be a little higher because this includes a lot of patients with COPD and other types of diseases that have a much higher expenditure than the types of diseases children would be treated for. Whereas if we go down to circulatory diseases, so things like hypertension, angina, heart attack or heart failure, only about 1.2% of all treatments for children under the age of, or from 18 and under, are circulatory type diseases. Whereas for adults, it's the most common disease category at 18%. Right? And what is the average expense? Almost 3 times higher than that of respiratory diseases, at almost $3,000. But it's experiencing a much lower average inflation rate. Okay? So, in this table, what I've done is I've actually broken down the inflation rate for each individual age group. So I've created what you think of as age-based medical care expenditure indexes. So on the top of the table, we have the larger age categories, right? So you have children, you have working age adults, and you have the elderly, right? And then below that you have, children, prime working age, etc. You have 6 different categories instead. And so in this case, what you can see is that there's a very clear trend in expenditures. As a person's getting older, right, or going to a different age group, then what's happening to the average inflation rate for that particular age group? It's actually falling, right? And that's because of the types of services or the types of treatments that they're actually receiving. And you see that across, the median by using the estimator as well. Now, I've also included on this final column the growth rate in utilization, right? And so I have that listed at the bottom where I've actually defined Q using the quantity PASH index, where price is held constant for each type of service, and then I allow Q to change, right? So I'm looking at how the weighted quantity for each service type is changing, right? And what we see is that, for young individuals, children, then utilization is actually growing, meaning that more resources, more inputs are actually being used to treat these children, right? And pretty large in percentage terms, right? 0.2% growth on average each year. Now, for other age categories, then utilization is actually falling, which would indicate that productivity is growing, right? Now, of course, like I said, the way the BLS calculates productivity for the healthcare sector, it's close to about 0% or actually negative, right? Now, here, what we're actually seeing is that when you calculate medical care from a disease treatment perspective, then utilization is falling, or meaning that productivity is actually growing. Now, for a lot of individuals, right, it's not growing by very much. However, for elderly, it's actually growing by fairly significant amounts, right? For those over the age of 65, it's growing between 1.7 and 2.5% per year, which is much, much better than 0, right? So, as people age, what we see is that the rate of inflation is negatively correlated with age, right? And what we see is that that's due mostly to changes in utilization across age groups. And this changes in utilization explains a lot of it. If there's a 1% increase in the amount of treatment outputs, weighted by expenditure, then that leads to about a 1.06% increase in the inflation rate, according to this previous table, right? Now, from a personal perspective, though, like I said, the inflation rate's going to be much larger. And that's because the total expense of treatments is positively correlated with age. Right? So if you look at, say, a 60-year-old individual in our sample, he spends roughly 3.5, almost 4 times as much for each treatment as the average 10-year-old, right? Which makes a lot of sense. Now, of course, this is completely different type argument than is made when you're talking about changing demographics. When you're talking about changing demographics, you're thinking about the fact that over the last 50 years, the average age in the United States has gone from about 30 to about 35. Now, the change in expenditures for a 30-year-old and a 35 isn't very much. However, in that same 50-year time period, that 10-year-old boy became 60 years old, right? And so from that individual's perspective, then he is spending a lot more per medical treatment, right? So, think about if you have an investment that, over the course of 50 years quadruples. Now, that might not be a very high amount of return, right? But if that's a return in addition to other returns, right, then that's pretty significant. And that's what we're seeing here when we're talking about medical care inflation at the personal level. And this is not being accounted for in other types of price indices for medical care. And so, in order to determine how much this is, basically estimate the following model, where we run this regression of the natural logarithm of expenditures, right, for a medical episode, I, in time period T, on both the age of the patient with that medical episode in the time period that episode is taking place, right? And so what that gives us is that the inflation rate is going to be roughly equal to beta 1 plus beta 2, or the coefficients on those two. Okay. And so, let's do this. Now, in my paper, I also do this in a few other ways, but for the purpose of this presentation, I think it's easier just to show this chart and table. Okay. Now, what we can see is that for everyone, all age groups included, then the effect of aging is almost 1%, meaning that going from the age of 30 to 31 adds roughly 1% to the price of your treatment. That's not being accounted for in the MCE or other types of indexes. Right? And that's in addition to the actual price of the treatment going up. Right? Now, for when you're young, a child, then that's actually going down by 1%. Which is pretty easy to see. Most of your expenditures as a child is when you're like a little bitty baby or kid, but then as you get older, you tend to have fewer medical expenditures, right? Your treatments start becoming things more like receiving vaccines or very, very minor type of treatments. However, as you get older, once you become in the working age group, then the effect of aging is pretty significant, right? Now, whenever going from year to year, your average expenditure, your average price per treatment is going up over 1%. And that's purely due to the fact that you're getting older and the price of and the types of treatments that you're now receiving are becoming more expensive. Okay? Now, when you're already old, though, the effect of aging isn't very much. If you have things like diabetes or have heart disease, then they probably have already appeared in some form or fashion by the time you become 65 or older. And so becoming even older doesn't really seem to have too much of an effect. Right? Okay. And the important thing also to see here, and this was true in the last graph, is that, for the elderly, this inflation rate, 1.7% is much, much, much lower than the other groups in the economy. In fact, this is, much lower than even the headline rate of inflation, 0.8% lower over this time period, right? So, what does that mean when we compare, say, young adults to elderly? Well, young adults are really experiencing the greatest level of medical care inflation within the economy. And that's for two reasons. One, it's because the cost of those common treatments, right, by young adults is growing relatively faster than the cost of treatments for elderly individuals, right? And that's mostly because these treatments are not experiencing as much of a reduction in utilization as those for elderly individuals. However, that's not the only effect. In addition, they begin using they start, as you get older, the young adults begin being treated for more expensive diseases, right? And that effect is not insignificant. Roughly 1% added to medical expenditure inflation every year, right? And if we think about it, when we're thinking about in terms of inflation, one of the important things is that, inflation affects how individuals make decisions, how they plan ahead. And do you think that young adults take into consideration the fact that as they get older, they're probably going to be spending a lot more on medical care? Maybe not when they're 18, 19, 20, 25, but once they start getting about 30 to 40, definitely, right? So, let's look at an application of this just really quickly, right? And this application is through, say, the cost of living, which, the CPI, one of the biggest reasons why it's important to accurately estimate the CPI is the fact that a lot of payments are adjusted every year by the CPI, the Consumer Price Index. And of course, we call that indexing, right? So, over 90% of the individuals who are age 65 or older actually receive some type of Social Security benefits which are indexed to inflation. Specifically, they're indexed to the CPI for workers. And this includes about 38 million retired workers in 2013. So, what was that, like 12-13% of the population receives some type of Social Security benefit. Okay? Now, the biggest problem, though, according to a lot of people, is that the CPI for workers, which is what they use to index Social Security payments, is that it does not accurately represent the basket of goods that are actually used by the elderly, right? Specifically, it's the fact that elderly people buy a lot more medical care, right, than younger individuals. In fact, the estimate is roughly that 11.3% of elderly people's income is spent on health care versus only 5.5% for the average worker. Right? And so it's because of this that the Bureau of Labor Statistics actually publishes an experimental index called the CPI for elderly. And the thing is that a lot of people actually argue that the CPI for the elderly should be the inflation rate that is used to index Social Security payments, since theoretically it's more accurate, right? It more accurately describes the inflation rate that's experienced by the elderly. But there's a problem to that, right? And the problem is that the CPI for elderly, all they do is they just weight the medical care component of the CPI by a greater amount. But as I just got finished discussing throughout this paper, is that elderly individuals receive or experience a much lower rate of medical care inflation than younger individuals, right? Much lower. We even found that it was lower than the headline rate of inflation. Now, if they spend a lot more on their income, right, then that's just because their treatments are more expensive on average. So, if we want to so a lot of people argue then that if you actually switch to using the CPI for elderly individuals, the Social Security payments would actually have grown by about 0.2% more each year, which when you think about compounding over 20, 30, 40 years, then that's a significant amount more money that the elderly would be receiving now than that they aren't, right? So, what would happen if we actually adjusted and compared the CPI for elderly with the CPI for workers using my different cost adjustments for medical care inflation, including that aging bias that's going on. Though, of course, we wouldn't even have to include the aging bias to still get at this outcome. All right, this just makes it a little bit more stark. If we adjusted for all of that, then we would actually find that the CPI for elderly individuals would be lower than the CPI for workers, right? In fact, it'd be about 0.05% lower each year, meaning that perhaps elderly are being overpaid, right, for Social Security benefits. Now, that doesn't necessarily, this does not mean that I'm arguing that we should be using the CPI for the elderly instead of the CPI for the worker with my aging adjustment, right? Because as I got finished talking about earlier in this presentation, there's a lot of outliers in healthcare spending, right? And so, older individuals, though they are experiencing lower rates of inflation, also have a much higher variance in healthcare expenditures as well, right? And so it would probably not be prudent to actually go ahead and use necessarily this specific type of adjustment, but it's something important to keep into consideration. Now, one thing that I have failed to do so far in this in these figures is to actually look at the how much is actually paid, the self-expenditures by the elderly individuals. So when I was comparing expenditures, I was looking at total expenditures paid not only by the elderly individual, but also by their insurance company, Medicare, Medicaid, and anyone else that is paying, anyone who's paying for this particular treatment. Now, if I actually look at the out-of-pocket expenses, then there'd be an even greater difference between the inflation rate that elderly individuals face and the rest of normal workers in the economy. Okay? So, in conclusion, what I've argued is that the medical care component of the CPI really is a poor measure of inflation, right? Because it doesn't take into consideration any productivity gains, innovations, quality adjustments, any of those things that are actually taking place in the medical care sector, right? And so, just from that productivity standpoint, then this medical care component should overstate inflation. All right? And so that would make it where the MCE, which does take into account productivity, would be a much better estimate of medical care inflation. But the problem is that that's not completely true, right? And that's because there are two other effects that that lead to the MCE being downwardly biased, right? One is the fact of the treatment of outliers, and we found that outliers could cause if outliers are properly accounted for, they could cause the MCE to grow by about 0.3% more per year, right? But an even bigger component is this effect of aging, right? The fact is that the typical healthcare consumer expenditures are growing much higher than what is found just by this, by calculating the MCE in that particular method. That's because people are getting older and they're using a different mix of services. Okay? And so once we take all that into consideration, what do we find? That the medical care component of the CPI doesn't overstate inflation, for most of the population. Now, it does overstate it for the elderly, right? But so does the MCE. But the medical care component of the CPI more likely understates inflation for working age adults, or how much they're actually paying year to year from their own perspective. Okay? I'd like to thank you very much for listening to my presentation, and have a good day.